Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week summaries, which this week were brought to you by our authors Samuel Rouleau, Vivian Lay, Babatunda Carew, Seth Walsh-Blackmore, Kimiko Dunbar, and of course, Clay Smith. Okay, without further ado, let's get straight into the first article, which was titled Diagnosis and Management of Community-Acquired Pneumonia, an official American Thoracic Society clinical practice guideline out of the American Journal of Respirology and Critical Care Medicine. Pneumonia, of course, is a very common condition, so we have to stay up to date on its treatment. Let's talk about a few things that were just recently weighed in on by the American Thoracic Society on community-acquired pneumonia. So first, let's talk about diagnosis. Now, is lung ultrasound a reasonable alternative to getting a chest x-ray when you're trying to diagnose pneumonia? And the answer is, of course, yes, which we've known for quite a while. The ultrasound is a really good tool for this. It's very reasonable. In fact, it's better than X-ray when performed well, with a median sensitivity of 95% and a specificity of 75%, compared to getting a chest X-ray, which has a sensitivity of 70% and a specificity of only 55%, which of course is really not a very good test. And I'm surprised we do it as much as we do when the test characteristics are that bad. The findings that you're looking for when doing an ultrasound of the lungs are pleural irregularities. So when you see that kind of lung sliding, you can see it's not usual. It's kind of, you can see the shred sign. You can see air bronchograms. You can see pleural effusions. You can see B lines, which can often be focal and not like when you have fluid in the lungs and then it's going to be kind of diffuse and bibasilar, but focal B lines. That's really looking like a pneumonia. The catch to all of this is that, well, it's tedious, it's kind of cumbersome. If you want to do a full lung protocol, you have to do 6 windows on each lung. So you're doing 12 spots that you're checking. This doesn't actually take that long because it doesn't take very long to look at each spot, but you still got to do 12 spots, which means that your patient needs to be properly gowned for this. You have to be able to do this. It's a little bit easier to do on a male. And so it's a little bit cumbersome to do. But it is a great test. I just wish that I had perhaps, a technician or something like that to take care of it for me. That'd be really nice. Now, the next question that they wanted to answer was whether or not in presumed community-acquired pneumonia, should you still treat them if they have a positive viral testing? Now, I didn't know anyone was asking this question at all. Of course, it's very hard to differentiate between a viral pneumonia and a bacterial pneumonia, but viral superinfection is a thing, and then you're not going to be able to tell which is which because they're likely both going to be present. And when we try to look at this in children, specifically febrile infants, we see that, okay, it doesn't mean nothing to be positive for a virus, but is it enough to say that you don't have a bacterial infection? No, not really. And so despite the fact that there's really no evidence, no trials actually comparing, treating, or withholding antibiotics in patients who are positive or negative for viral testing, I'm surprised that they decided to weigh in on this at all. I don't think it's very helpful for guidelines to give weak, low-quality recommendations rather than just saying, hey, decide for yourself, the jury's still out, and calling for more research. They went ahead, though, and made the recommendation that if you're being treated as an outpatient, you have positive viral testing and no comorbidities, it might be reasonable to withhold antibiotics. However, in pretty much everybody else, you should still give the antibiotics. I'd say, this is kind of weak. I don't know that viral testing is really going to change much for me. Personally, it takes a while to get viral testing back, and it's not something that I'm going to wait for these patients. I don't really have time for that. Plus, I don't really want to hang my head on it either. Frankly, patients who can be outpatients who are perfectly healthy and have no comorbidities, most of them are going to get over even a bacterial pneumonia. So whether or not the viral testing is positive or not, frankly, the patient's probably going to be okay. So it's really going to depend a little bit on how they're doing. Do they need antibiotics or not? That viral testing, personally, is not going to change my management. Next, they wanted to comment on the duration of antibiotics and whether or not we can give less than 5 days of antibiotics for patients with community-acquired pneumonia. Now, traditionally, you treat people for like 2 weeks, But now there's some evidence that shows that shorter courses seem to be pretty good. But it's hard to generalize all of these studies to every population. For example, some of the studies used macrolides, which is not necessarily advisable in every population due to high resistance rates. Other trials looked at hospitalized patients where you can monitor that patient every day and decide whether or not they need antibiotics anymore. So I think this is hard to do for outpatient management. If they're admitted to the hospital, however, I think then you can make a day-to-day call on whether or not this patient still needs antibiotics. For the outpatient setting, for the emergency room setting though, I don't think this is a good one. Treating for less than 5 days seems maybe a bit short unless we get more evidence on this. And then finally, the last question they wanted to answer was whether or not you should give steroids to patients with community-acquired pneumonia. And if they are hospitalized, the answer is still yes. You look at big trials like Cape Cod and all of those. If you're severely ill and hospitalized, then steroids are going to help you. If you're an outpatient, you have non-severe community-acquired pneumonia, you don't need oxygen therapy, then steroids, not so helpful. Overall, I think this is a pretty good summary. I think these are pretty relevant questions to be asking. However, with the amount of data on hand for some of them, I don't know that we should be getting guidelines on them unless we have a little bit more data. People tend to over-exaggerate how much guidelines should be guiding us. So I think guideline distributing organizations should be just, a little bit more cautious with this before putting out weak recommendations based on low-quality evidence. In a spoonful, there were a few relevant questions about community-acquired pneumonia, which were answered by these guidelines. And then we skip straight to the third article, titled a whole bunch of different organizations and associations. These are guidelines for the prevention, detection, evaluation, and management of high blood pressure in adults. A report of the American College of Cardiology and the American Heart Association Joint Committee on Clinical Practice Guidelines out of the journal Hypertension. Now, as emergentologists, we don't spend that much time treating hypertension. Sure, the odd person comes in with a hypertensive emergency, but for the most part, the data really seems to be quite clear that I just don't care if the patient has hypertension. You don't really want to start treatment out of the emergency department. That can be harmful. But all the same, it's good that we know what's going on in the world of hypertension and what are the recommendations that we know if we need to set our patients up with future follow-up, even if we're not handling it ourselves necessarily. Now, guidelines over the years have gotten more and more strict, and indeed now normal blood pressure is defined as less than 120 over less than 80. So anything over that regularly with at least 2 readings of abnormal can be used to give a diagnosis of hypertension is hypertension, which is really very strict. We've slowly gotten more and more strict, but it seems like the data seems to show that stricter targets are better targets, and then you get better long-term outcomes. A lot of these diagnoses, however, are going to have to be made with fully automated devices, 24-hour monitoring, home BP setups, and not just one measurement done at triage with terrible technique. Don't take that blood pressure. That blood pressure is not a good blood pressure. So the targets for actually treating this are typically less than 130 over 80, but we'd love to see people at less than 120 over 80. Every patient over 140 over 90 is supposed to get medical treatment. However, patients who are just over 130 over 80, they should still get medical treatment, but only after they've tried 3 to 6 months of lifestyle modifications. As for that medical therapy, the recommendation now is actually a 2-agent combination pill to start, preferably not 2 separate pills, but a combination pill. We don't want to give our patients too many pills to take. I'm not going to get too much into it. Not too much has changed on the actual agents that you want to pick, depending on what comorbidities your patient has. Like, if you just want to start with the calcium channel blocker in a perfectly healthy person, while in this case now we're recommending 2-agent pills, anyways, but if they have diabetes, then obviously you want to start an ACE or an ARB. Anyways, there's a bunch of considerations to take into account, but they specifically say that even if you have severe hypertension, this is an outpatient treatment problem. So even if you come in and your blood pressure is over 180 over 120, they just say above that, who cares what the value is? This is an outpatient problem, unless they have organ failure. Different story. Indeed, if you look at their definitions, they've now removed hypertensive urgency. It no longer exists. It's just called severe hypertension, which, as I said, is an outpatient treatment problem. Now, they, of course, comment on a whole bunch of other things in these guidelines. It was over 100 pages about resistant hypertension, screening for secondary hypertension, but I think that's the summary of everything that's really relevant for the emergency department. So in a spoonful, while we don't typically treat it, these are still important guidelines and updates about hypertension management. All right, that's all the articles from this week. What did we learn? From the first article, we had an update on the latest of community-acquired pneumonia. From the third article, we saw the AHA's updates on hypertension guidelines, stuff that we actually need to know. If you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What things did you miss? First off, we did a dose-finding study to see what the best dose of intranasal midazolam is for procedural sedation in children. Then we looked at an enormous RCT looking at oxygen targets for ICU patients. And then finally, the American Association of Pediatrics has new updates for the 2025-2026 season for influenza. Links to all the original articles can be found at journalfeed.org, or just follow those links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.